Okay. So welcome everybody. We are going to have Dr. Kamiar Miras-Kandari host our session today with two residents, Yogesh Patodia and Anish Ratnam. So Kamiar joined our staff in 2009 at Sick Kids, and he studied his medicine in England, where he also received a PhD in ocular repair and regeneration at the Ocular Repair and Regeneration Biology Unit at University College London. Now, he is double fellowship trained in both pediatrics as well as cornea and external disease. He's the co-director of the Fully Comprehensive Pediatric Cornea and External Disease Fellowship at Sick Kids, which happens to be the first dedicated fellowship in the world. So welcome to Kamiar and to the two residents, and we can begin. Thank you.
Thank you very much. Thank you. So these guys have worked very hard to prepare two very complicated cases. And basically, through the discussions of this, hopefully we'll come across a few key points involving compliance with treatment and how it can really help us or fight us when we're trying to manage these patients. And I think just the general applicable processes in ophthalmology, but obviously these two are more pediatric orientated. So I think because there might be some discussions and the time is potentially short, we'll get Yogesh to start. Thank you very much.
Perfect. So we'll just get our screen shared there. Fantastic. So again, thank you, everyone. Again, my name is Yogesh Patodia. I'm one of the PGY3 residents, and I'm going to be here chatting to you about a case called Treatment Compliance Makes All the Difference. And again, I'd like to thank Dr. Miras-Kandari for all his help with putting the case together, and of course the imaging technicians at Sick Kids for their fantastic images and allowing us to kind of share a lot of cool pictures with you guys today. So there we go. Let's get right into the curious case of LH. So she's a 16-year-old girl, sickle cell disease with homozygous SS. Now, she's been known to have a significant amount of iron overload, and very commonly at Sick Kids gets transfusions almost monthly. Now, of note, what we should know is sickle cell patients obviously have a risk of auto-infarcting or auto-splenectomizing and losing their spleen, and thus being very at risk of encapsulated bacterial infections. Now, our lady here, interestingly enough, still has her spleen, but she does have areas of basically may represent some infarcts within her spleen, suggestive of some poor function. And so because of this, she was vaccinated against a few strains of pneumococci. But interestingly of note, she was never placed on any formal antibiotic prophylaxis. Interestingly enough with her as well, due to this hyperviscosity of her blood, she developed multiple silent strokes over the frontoparietal, right ACA region, occipital and parietal lobe. And again, showing here in the occipital lobe. And the psychiatrists at Sick Kids believe that she may have developed a sort of neuropsychiatric disease related to these silent strokes, maybe some personality changes. Of note, she's also had a lot of chronic anxiety and depression due to this. And of course, given the length of her chronic disease and her frequent trips to Sick Kids, she's unfortunately developed a lot of frustration behind her disease. Now, of course, she's on hydroxyurea. Neurology has placed her on ASA, which unfortunately she's been non-compliant with, and has been returning back to the emerge with multiple neurologic-like symptoms that may have been related around more silent strokes or even a potential new one, as well as quite a lot of hydromorphone. She unfortunately has a lot of pain crises, missed a lot of school due to his falling behind, and often gets very depressed and stressed about that as well. So let's jump right to that presentation where we get involved. She presented to Sick Kids Emerge with a day of nausea, vomiting, and fever. And of note, she has a 4-year-old contact who's sick, her 4-year-old sister. But what's really important here is that she complained of generalized weakness. And the interesting point was she was able to walk from her home to the car. But upon arriving to Sick Kids, she really needed a lot of assistance to get from her car to the Sick Kids Emerge. And so of note, hematology, who's her primary team, kind of assessed her in the Emerge bed and noticed that she was constantly falling asleep, noticed that she had these really odd eye movements, and that she had this 1 hour of foggy vision that she complained of. Now, putting on, so again, given her history of previous strokes, a stat MRI was ordered. And of note as well, in this image here, we can see that she's had these large areas of basically diffusion restriction in the posterior parietal lobe, the occipital lobe, the posterior temporal lobe. And then there were some areas of small periventricular infarcts and intraventricular pus. Now, putting this all together and using our kind of internal medicine hats here, we'll get into the first poll question. Emrit, if you'd like to put that up there. So what would the workup include in this case? And pretty straightforward here, but would it be, just a plain CBC, a lumbar puncture, peripheral bug culture, an ophthalmology consult, given that she's had these weird eye movements, and some decreased vision, or all of the above?
Okay, we'll just give some time. We got quite a bit of votes. I'll just end that there. It's been 30 seconds.
Fantastic. Well, 7% of people are just like, go straight to ophthalmology. So thankfully, 1 through 3 were done, but unfortunately, right in the acute phase, ophthalmology was not consulted in the first day or so. But let's go over some of her workup that she's done here. So again, her CBC did show an elevated white count. Blood culture showed streptococcal pneumonia, that grew in the blood. And then as well as a lumbar puncture showed gram-positive cocci, but unfortunately didn't grow anything after that. So she was given the presumptive diagnosis with strep pneumobacteremia with a meningoencephalitis and was immediately started on ceftriaxone, acyclovir, and vancomycin. Now, we were waiting and waiting and waiting, and finally, about a day after, ophthalmology was finally called. And the hardworking fellow went up to the floor, saw the patient at the bedside, and she was 20/25 in both eyes. Anterior segment exam was relatively normal, but unfortunately, this visit she refused dilation. She outright said, "I'm not getting it done. I want to be able to read. I want to see my iPad." And with as much pushing as the fellow could, unfortunately, she declined. And at the time, we said, "Listen, please call us back whenever she's ready to get, whenever she's ready to get dilated, and we can do a proper bedside exam." We couldn't bring her down to clinic because she was still a little bit, still a little sleepy, unable to walk. So we kind of waited and waited. And finally, over the next 2 days, she started developing ongoing blurred vision, floaters, and some eye pain. And as you can see, her vision unfortunately dropped to 2160 in the right and 2400 in the left. And again, looking at the anterior segment photos here, or the anterior segment photos here, we see a lot of conjunction. Again, there may be a small hypopyon here in the right eye, but more importantly, there appears to be these opacities kind of sitting behind the lens. And our next question is, well, what does the fundus look like? This is what the fundus looks like. So unfortunately, a significant amount of vitritis in both eyes. And you can kind of appreciate, this is not the optic nerve right here. The optic nerve is over here, but she has these, fluffy white lesions that appear to be kind of mid-periphery in the right eye. And of course, this is what's concerning, this parafoveal or foveal fluffy white lesion. So she was given the presumptive diagnosis of bilateral endogenous endophthalmitis, and it was decided to do an urgent tap and inject. AC taps were done mainly to manage the pressure. We already had a positive culture, so we had a feeling what the source was, but you send it off anyways, which came back negative. She was injected with ceftaz and vancomycin and started on PO moxifloxacin, which has good ocular penetrance, as well as her primary team switched her to IV penicillin given the sensitivity reports from her bacteremia. So within 4 days, her clinical picture started to improve. She was able to walk, talk, she was more alert, awake, and felt better in her bed. But unfortunately, her eyes still were, mildly improving, about 2100 count fingers in the left, quite a bit of inflammation in the front of the eye there. But more importantly, as we show here, the fundus photos, are the wide field photos here, there is a good improvement in the vitritis in both eyes. Again, the left eye is just a little bit worse. And now we're able to really appreciate these sort of chorioretinal lesions in the mid-periphery here with some intraretinal hemorrhaging. And again, the same thing in the left eye here. Again, a lot of vitritis, but you're able to really appreciate that chorioretinal lesion that's sort of parafoveally there. Jumping to day 6, we see a pretty good improvement in the vision. And again, clearing of the vitritis, and again, consolidation of those areas where that chorioretinitis was. Now, of note, I'd like to point out here, most people would look at this and go, oh my God, is there a reactivation of the of her endogenous endophthalmitis? But one thing of note that we should say is that wide field imaging unfortunately magnifies floaters and it kind of makes them look a lot larger than they really are. And this likely was just, a vitreous floater that was magnified with the Optos imaging there. So it's just something to kind of monitor and see on her day-to-day visits or her weekly visits. Now we'll also show you the OCT images of this. And again, the very interesting kind of picture that we're seeing here. The right eye looks to be relatively normal in the foveal region. Again, just a little bit of vitritis. You can see some vitreous cells here. But in the left eye here, I'd like to point out that parafoveal lesion that was there, that was actually highly concerning to be kind of on the fovea. You can appreciate the area of atrophy that there now used to be. Again, this was more suggestive, and we'll get into a couple more of these, that there was a sort of or choroidal nature of this infection that kind of pushed up through subretinally in through the retina, and of course into the vitreous. And so you could see either there's some atrophy now occurring over here, or as well as maybe just remaining a little bit of the infiltrate that's still there. Now, finally, at 2 weeks at discharge, her vision maybe declined a little bit, but more importantly, looking at her fundus photos, you can see a significant improvement in kind of the consolidation of these chorioretinal lesions, again, suggesting that there is a good improvement. Now, her vision did sort of wax and wane between every visit when she was an inpatient, so it's difficult to say if there was really a big improvement, but again, looking just physically at her eyes, there was an improvement in the endogenous endophthalmitis, or the lesions. And again, I'd like to point out here as well, the slices were taken a little bit differently here, but again, the right eye through the fovea looked relatively normal. But of course, in the left eye, you can really appreciate kind of these areas of subretinal infiltrates. Again, suggestive that there was a sort of a choroid lesion that sort of pushed up through the retina into the retina and then into the vitreous. So you're able to sort of watch and follow the OCT images if you're able to get sections through the same area. And again, still quite a lot of vitritis, but overall improving. And out to post-op month one here, doing fantastic. 20/30 in the right, 20/50 in the left. We did, Dr. Mears-Kandari did fantastic. She's doing really well managing her treatment. We were happy, but unfortunately, history repeated itself. She's had a lot of non-compliance issues or compliance issues with her ASA in the past that resulted in multiple kind of silent strokes. And she was supposed to be on moxifloxacin for about 6 weeks, as well as ceftriaxone via PICC line. But despite all the Jedi mind tricks, she was unfortunately very poorly compliant with her medications. She didn't really go to the center where she got her ceftriaxone via the PICC line, and didn't really take many of the medications, the moxifloxacin, and she came back to us with decreased vision in the left eye. And of course, comparing post-op month 1 to post-op month 1.5, the big difference you can see here is, you can see a decent size increase in the chorioretinal lesions in the left eye. And again, same thing in the right eye. Again, there's maybe a little bit of interval increase between the two. And again, looking at the OCT imaging, and this was at post-op week 2 and at 1.5, you can kind of appreciate the increase in what's likely that subretinal infiltrate. You can see that here it's quite small. And again, through the same segment there, it's increased in size. And again, looking at the heat map as well over here, you can see that there is maybe a new area. What used to be atrophied is now kind of elevated in size, suggesting that the infection is unfortunately back. So she was admitted under ophthalmology for an urgent repeat bilateral tap and inject. She had some ceftaz and vancomycin intravitreally again, and restarted back on her moxifloxacin. But more importantly, she was educated on the compliance of her medications. And, we really talked about the ramifications of not taking your medications and what can occur. The big thing, she kind of saw what happened when she stopped taking her medications. She came back with worsening vision. And more importantly, at this admission visit, she was thankfully, her primary team started on prophylactic penicillin. And since then, she's been fantastic, very compliant with her medications, has been very regular with her penicillin. And thankfully, we can look at, again, following up here, post-op day 1 looked relatively stable. But most importantly here at post-op month 1, you can see, again, consolidation and even a little bit of scarring down of these lesions, both in the right and left eye. And then most importantly, at post-op year 1, she was doing absolutely fantastic. Very clear vitreous, basically complete scarring of these lesions. And most importantly, her vision's 20/20 in the right and 20/25 in the left. So again, what was very concerning, especially in the left eye, for a very poor outcome, thankfully ended up turning out very good. But again, compliance was a really big issue. And if the compliance was there or was not there, or if she waited any longer, theoretically this could have gone foveally, and it would have been a lot more devastating. So this brings up to the question of medication compliance in pediatrics. Now, unfortunately, it ranges anywhere from 11 to 93% in the literature. And of course, urban adolescents, unfortunately, have poor compliance compared to suburban adolescents. Now, there are many factors that play into this, and in our case in specific, socioeconomic status played a role. Unfortunately, those in lower socioeconomic status have poorer compliance with their medications. Physician-patient relationship is very important, something we can all kind of garner with our patients. In this case, the older the patient, the less compliant they are with their medications. Again, when you're younger, your parents force you to take the medications, and that's it. But unfortunately, as you become older, get into your teenage years, you start to take your own healthcare in your own hands, and that's where we start to lose a little bit of the compliance. And again, with our case as well, patient education and disease duration played a very important role as well in the non-compliance. Again, educating the patients and making sure they understand the ramifications that come from these is really important. And of course, the longer the duration, the longer duration of the disease, the more fatigue there is involved and the poorer the compliance. So many studies have also identified the importance of compliance. There's decreased office visits, decreased hospital admissions, there's decreased changes in medication. And of course, in most cases, the illness course can usually be a little bit shorter. But we all know that there are many barriers that are really associated with this. And of course, limited physician time is one of the bigger ones more recently. Again, worse during COVID is we're really not able to see as many patients as we used to be able to see. Patient-family dynamics, route of administration of the medication, costs and adverse effects really play a really large role. So again, if you can limit some of those factors and they may help with patient medication compliance down the road. So big takeaways I'd like to kind of mention is that compliance may be the root of recurrent disease. Wide field imaging really does play a role in disease management. And as we were able to see in this case, OCTing of the lesions or OCT of the lesions actually helps with monitoring disease progression. Dilating that primary visit may have caught an early endophthalmitis. So again, really, I know we get harped on it in residency, dilating. I think especially at that first visit, in many cases like this, it's really important to dilate to, see what's going on in the back. And building a really strong patient-physician relationship, it kind of helps decrease cases like this. And finally, a little internal medicine note, all of our sickle cell patients who are autosplenectomized or splenectomized, again, so have functional asplenia or asplenic, should be on some sort of antibiotic prophylaxis. And it's a good idea to work with our infectious disease colleagues, if they're not on the proper medications, just to ensure that they are on something prophylactic towards encapsulated bacteria. Again, had she been on something for this, there might have been, a potential to prevent something like this from happening. But thankfully, a good result that kind of came out of it at the end. So I'd just like to say thank you, and if there are any questions.
Thank you for that, Yogesh. That was a great run through quite a complicated case. So thanks for doing that. Maybe we'll just open it up to the floor, or if any of the panelists have any questions. I really like the fact that you reminded everybody to dilate every patient. I mean, it's the one thing that we always do at Sick Kids, is because you cannot rely on the history necessarily. So kids may just say, oh, the vision's a little bit foggy, whereas an adult would specifically say, I've got these floaters moving around. So you may not have the history in the same way to guide you in terms of, okay, floaters in a case of potential septicemia is very significant, as opposed to somebody who's got sort of neurocauses for her vision to wane. And then you kind of think to yourself, is there something else going on? So I think let's look at the chat.
Camille, could I just ask a question, Dave Smith? I was wondering why you didn't offer her phenylephrine to dilate her instead of cyclopentolate. She could have still read and you have had a dilated pupil.
That's a very good question. So I'm not sure if I can talk to the exact scenario, but I think remembering what the fellow's description was, it's just that she just refused anything. It wasn't necessarily, I think we were talking about she was probably didn't want to be dilated, but I suspect being of African origin, it may not have done enough, and she just did not want to have any drops in her eyes. But maybe a detailed explanation of maybe this drop will not blur you as much. It may not work in the same way as well. Would have been something to try, but I have a feeling from knowing her and the intervention or the discussions with the fellow that this probably was it was not going to work. And obviously we kind of had a sort of discussion around this case because we probably felt this was quite a near miss, as you can imagine. and that initial dilation could have given us a better clue. It kind of fortunately turned out okay, but in theory, you want to get to endophthalmitis as soon as possible, and potentially a day or two's delay is not ideal. She actually got injected within 2 hours of us sort of seeing her in clinic. So basically just ran up and did that in the OR. So we kind of minimized the delay in that respect, but surely if we had seen something at the beginning, could have been dealt differently. But that's a very good point. Just going through that, getting into the patient's head, saying, what is it that you're really worried about? She might have just wanted to FaceTime her friend and she didn't want to be blurred, and just dilation with phenylephrine, if that was explained, might have been a little bit more helpful. And I guess the other thing is that our fellows literally have about 200 consults probably a month about query endophthalmitis with all these septic patients, which are almost always negative. And then you see somebody who's 20, 25 and really giving you big attitude, and you may be busy otherwise. I can just see how they probably sort of guesstimated that there's unlikely to be a problem. But I think it's just the lesson for us all, really, that, just because you have 200 consults that are negative for endophthalmitis doesn't mean this one will be, unfortunately. But a very good point about the phenylephrine. So
okay, can I ask about the antibiotic prophylaxis? I'm pretty rusty on my internal medicine now, and I certainly remember that the asplenic patients required various vaccinations. Is this just a sickle cell thing that they should be on it? And also, how do you, there must be some dangers to keeping someone on antibiotic prophylaxis for life in terms of colonization and resistance and whatnot. So do we have any more information about that? Are we expecting all asplenic patients now should be on antibiotics, and what type?
Go ahead, Yogesh, do you want to answer?
Yeah. So typically, typically making sure that they're vaccinated is kind of a really important, part, against the encapsulated bacterias. I think they look at like risk stratification, and if you're kind of at a higher risk, again, younger kids, school born, if you're at a higher risk, it's probably a good idea to be on some sort of long-term prophylaxis. And again, I think they start with something very low key like penicillin, something that, if there isn't a resistance built up to it, there are other medications in their armamentarium to use against them. Not typically everyone is on some sort of long-term prophylaxis, but I think it was really mainly based off of risk stratification. So again, given that I think her living situation was unfortunately kind of difficult too. And then her be going to school and everything, she was at a higher risk of getting infection. So she should have been on something a lot earlier on, but it was unclear given the infarct that she had in her spleen, whether or not if it was fully functional or not. The thought was there was some function still there. So I think that's why her primary team kind of held back and didn't do anything at the time. But again, now having, a bacteremia because of this, they said, okay, listen, she's clearly is asplenic. Despite what our MRs and ultrasounds are showing. So in terms of your question, I think it's a good idea for those patients that are at higher risks to be on some sort of prophylaxis.
Great talk, Yogesh. Thank you. There's a question for you guys in the chat here from Sick Kids Ophthalmology. I don't know if that's Dr. Ali or somebody else, but there's a question about capacity in a patient with a history of multiple strokes and whether that would play a role here.
Yeah, I think it was. I think it that came into question a lot, given the history of her previous strokes and these changes in her personality. But she was very known to the psychiatric department there and the neurology department at Sick Kids, and they had done exams to see if her capacity was still there. And according to the notes, she was still able to make decisions for herself. They found that these strokes didn't, completely affect her ability to make decisions and smart decisions. She was still able to understand kind of what the ramifications would happen if she didn't take her medications or if she didn't choose the procedure, go ahead with it. So I think that's a good point that, with all of this, these neurological issues, it brings into the question, maybe she was not of capacity, but, thankfully they were able to say that, given their exams, she was of capacity to make decisions. She did have the proper capacity to make decisions.
Yeah, so
Perfect.
just to add to that very quickly is I think she was just a fed up teenager rather than I am unable to make decisions. I remember when trying to convince her to have the second tap and inject, basically she started crying and said no. And I just said, no, that's not your choice anymore. And mom, I turned around to mom, says consent, sign here, and we're going in. Same thing with the first injection. She just didn't want to have anything done. And I said, no. I said, you think you're depressed now, you won't be happier if you're blind and depressed. So it kind of, I had to be quite firm with her. I have to say, I occasionally have to do that. And I think she was just fed up. But
Yeah, and sadly, that's something we see, I mean, in the adult world with glaucoma all the time. And there is actually a question from Dr. Epstein, and I've promoted Dr. Graham Crope if he wants to take this question. But there's a question about shifting, and I don't mean to put him on the spot, but I know this is right down the glaucoma lane, about the shift from using the word compliance to adherence lately. So I don't know if anybody wants to touch upon that. If Dr. Crope's here, he may want to touch upon that. And in the meantime, maybe we can get Anisha's slides up.
I know maybe Graham, you're on mute. I definitely like the idea that it's not something that you're blaming the patient for, although I guess it's even adherence may imply that to a certain extent. But I think one problem that we have in our scenario, and I might just, if you have some time at the end, show some slides on this. But the problem is that as children grow older, and in the early teens specifically, we find this all the time, that parents start feeling that the children are now able to take over their own medications. And as far as they're concerned, they think, oh, well, you know, she's got a phone, so we just program 8 o'clock in the morning for the glaucoma drop, 8 a.m. in the afternoon for glaucoma, evening for the glaucoma drop, and they should do it. And basically what happens is that the alarm rings and the kid's chatting with her friends, so just turns off the alarm, carries on the chat, and then forgets that the alarm went off. So every time that any chronic disease, and we have these with blepharitis, uveitis, allergies, glaucoma, that is really not just going out of control, the first question I ask is, who's in charge of the drops? And invariably the parents say, oh yeah, she's doing it. And then you turn around to the kid and say, how many times are you missing this? And if they sort of in denial, I said, well, you know, if the drops are not working, then we may have to think about surgery. So is it really the drops not working, or they're not going in? And they kind of admit that they probably take it once a week. And then you go, well, see, there you go. And that's why the problem is there. So, and then you kind of have to constantly remind them. And in the very difficult cases, I just tell parents that, you know what, you have to take over the drops. I know she's 14 and she's acting or wants to be very responsible on many different levels, but you have to take it out of her hand, because this glaucoma will become surgical otherwise.
Yeah, exactly. And I think, I mean, to Nancy's point too, I mean, adherence and compliance are technically slightly different things. And adherence is basically the fact that you go to the pharmacy every month and you pick up your drops. And so I guess that's what the pharmacy or the insurance company might know, but compliance is actually taking it. But I think nonetheless, Camir's point is perfectly true, that ultimately we need to do this in a non-judgmental way. And this is, I mean, it's not just a kid's problem. I saw terrible glaucoma just yesterday in a 59-year-old, and this happened. So on that note, let's go over to Anisha's talk. Thank you, Yogesh, again.
Okay, good morning, everyone. My name is Anish Ratnam. I'm one of the PGY3 residents, and we'll be continuing on the theme of treatment compliance makes all the difference. Thanks to Dr. Miraz Kandari and the imaging department at SickKids for the ongoing support of this case. Case 2 is a 9-month-old male referred by an optometrist for right amblyopia and a rule-out intraocular mass. The patient was seen at 6 months old by an optometrist and also an ophthalmologist, and diagnosed with an iris cyst. Part-time occlusion of the left eye was initiated at that time. View of system showed severe eczema. Past ocular history was unremarkable. Pregnancy and birth history also unremarkable. The child was full term and healthy, and no allergies. On examination, the best corrected visual acuity was 0.6 cycles per degree and 2.4 cycles per degree in the left eye. Left eye was significantly better. Cycloplegic refraction showed some anisometropia. Pupils were equal and reactive in both eyes. The IOP was 9 and 12.
Anish, can I
Yes.
just stop you for a second? I think something is rubbing against the microphone or something, because we can hear something scratching on the microphone.
Oh, how's that?
Yeah, I think as you move the papers, it might have been scratching.
Okay.
Thank you. Sorry about that.
Strabismus assessment showed a right ET. And like I was saying, otherwise of note, the patient also had extremely bad facial eczema. So an urgent EOA was arranged, and we can see the external photos of the right eye showing a central nuclear opacity, a wedge of PS superiorly, and the obvious large pigmented sheath nasally. Gonioscopically, no angle structures were involved. The angle was open, grade 4, 360 degrees around. Fundus photos of the right eye, of both eyes, and show on the right and the left here, you can see an abnormality extending from the nerve to the pigmented plaque. The peripheral retina appears attached and uninvolved. However, nasally, there's no view. The left eye is within normal limits. And this brings us to our B scan. There's no obvious intraocular or choroidal lesions, and again, the retina appears attached. The UBM on the right shows a lesion arising from the ciliary process and onto the back of the lens, which you can see here. And this brings up our first poll question. What is the diagnosis? Retinal blastoma, familial exudative vitreoretinopathy, persistent fetal vasculature, or ciliary body melanoma?
Just give it about 30 seconds to run. We're getting a lot of votes in, so that's good.
There's a back-to-back poll as well.
Okay, I'll end it there.
Okay, great. And the next poll question is, how would you manage this patient? A, observe. B, urgent phaco, IOL, and posterior capsulotomy. C, observe with amblyopia management and delayed lensectomy. Or D, posterior capsulotomy, high lodal stalk release, and vitrectomy. Okay, interesting. Okay, so initially the patient was diagnosed with PFV with minimal posterior involvement. Close attention must be given to the high lodal stalk to be sure no retinal tissue is involved. Initially, the patient was given refractive correction with part-time occlusion of the left eye for 6 hours per day, plus dilation of the right eye, which showed a good paraxial visual axis. Between 2017 and 2018, visual acuity remained at 0.7 logMARs with telar acuity, with excellent compliance with patching. However, August 2018, there was some compliance issues with patching, and we decreased part-time occlusion to 3 hours per day in the left eye. And in follow-up, February 2019, visual acuity was 0.5 logMARs. It was at this point we stop, reassess, and respond, and determined that the child was not coping with the plateau in his vision he had obtained and resulted in unwillingness to comply. The decision was made for right eye phaco IOL, posterior capsulotomy, and anterior vitrectomy. In post-op care, part-time occlusion was continued, and compliance had actually improved now that his visual acuity had been further cleared. Bifocals were given in January of 2020, and at last visit, the right eye visual acuity was 20/70 and the left eye was 20/50, but tended to peer over the glasses due to poor fit. And in view of his severe eczema, protopic ointment was initiated in the clinic, although his parents went the naturopathic route and found dietary ways to treat his severe eczema. And this is a recent picture illustrating his skin improvement and right esotropia. As you can see along the course of management, there were issues with patching compliance, glasses fit, and glasses compliance, which is common in the pediatric population and which tends to add to the complexity in management. Patients commonly present with either leukocoria or abnormal red reflex. Therefore, a quick review is necessary. We should be thinking about cataracts, PFV, myelinated nerve fibers, retinopathy of prematurity, retinal detachment, fever, toxo, Coats disease, toxocariasis, retinoblastoma, retinal astrocytoma, retinal coloboma, and trauma. And important to note, anyone presenting with leukocoria or an abnormal red reflex, we should always think retinoblastoma before anything else. So persistent fetal vasculature was previously known as persistent hyperplastic primary vitreous. It can present with no clinical effects or with extensive clinical manifestations and severe morbidity, and is a cause for unilateral cataracts in children. In relation to pathogenesis, it arises from failure of the hyaloid vasculature to undergo normal programmed involution. During pathogenesis, it arises from failure of the hyaloid vasculature to undergo normal programmed involution. During development, this fetal vasculature nourishes the developing lens and vitreous. Any abnormalities along the involutional pathway produce the various manifestations of PFV. These are typically characterized as anterior, posterior, or combined. A quick note on embryogenesis. The hyaloid vasculature system begins developing by 4 to 5 weeks gestation. The hyaloid artery enters the optic cup inferiorly from the primitive dorsal ophthalmic artery and extends to the posterior pole of the lens. By 2 to 3 months gestation, the retinal vasculature begins to develop, which coincides with the beginning of hyaloid regression. Persistence of fetal vasculature is thought to be complex and multifactorial. The theories being related to dysregulation, dysregulation of apoptosis, irregular levels of anti-VEGF, and abnormal timing of genes and growth factor expression. Often patients are asymptomatic. However, vast and varied signs of PFV include leukocoria, strabismus, a shallow anterior chamber, angle closure glaucoma, a Mittendorf dot, microphthalmia, a dense retrolental plaques, as in our case here, cataracts, thick fibrous hyaloid artery, elongated ciliary processes, vitreous hemorrhage, and retinal detachment. Previous evidence-based approach to management involved early lensectomy and removal of any retrolental membranes, with posterior disease being managed by the vitreoretinal surgeon. It is important to remember appropriate patient selection is essential for both non-surgical and surgical approaches and avoided in patients with poor visual prognosis, with the focus on visual rehabilitation. As illustrated by this case today, a non-surgical approach can be successful and delay the need for lens-based surgery. There are numerous studies that look at management of PFV, however, none that compare non-surgical versus surgical approaches. The consensus, however, is that anatomical success does not always equate to functional improvement. However, all recommended aggressive amblyopia treatment to supplement cataract extraction. So pediatric cataracts are responsible for almost 10% of vision loss in children. They can be isolated or related to systemic disease, congenital or acquired, inherited or sporadic, uni or bilateral. In relation to etiology, bilateral cataracts are associated with chromosomal abnormalities, craniofacial syndromes, renal syndromes, metabolic disease, intrauterine infections, and iatrogenic causes, whereas unilateral cataracts tend to be more associated with ocular abnormalities such as PFV, posterior segment tumors, radiation, or trauma. Surgical management of cataracts in children is markedly different than adults. Considerations involve timing, managing and treating deprivation amblyopia, for instance. In unilateral cataracts, we aim to remove cataracts before 6 weeks of age and before 10 weeks in bilateral cataracts. We need to consider IOL implantation or aphakia. IOL implantation is typically accepted after 1 to 2 years of age. Before this age, there is a much higher risk of complications and larger shifts in refractive error. Intraoperative considerations involve careful manipulation of the capsule, as the anterior capsule is more elastic in children, and therefore the continuous curvilinear capsulorhexis should be directed perpendicular to the direction of the intended tear. Another note to consider is PCO occurs rapidly in children. Therefore, a posterior capsulotomy is performed to allow for a permanent and clear visual axis. So do we put in an IOL or not? The pediatric eye continues to elongate through the first decade of life. Selecting an appropriate IOL is very complicated. Power calculations can be unpredictable due to widely variable growth, difficulty in obtaining keratometry and axial lengths due to accuracy, and the use of power formulas that were designed for adults. Studies have shown a variable myopic shift of 7 to 8 diapers over the first decade. Therefore, if you made your patient emmetropic at age 1, by age 10, their refractive error could be -8 diopters or worse. Another interesting and important publication in JAMA Ophthalmology was from the Infant Aphakia Treatment Study Group, who conducted a randomized clinical trial with 5 years follow-up of 114 infants with unilateral congenital cataracts. They found there was no significant difference between the median visual acuity of those infants who underwent primary IOL implantation and those who were left aphakic. However, 81% of patients in the IOL group had 1 or more adverse events and additional intraoperative procedures. Their recommendation being to leave the child aphakic if less than 7 months old. And in relation to our case, our own study based here in Toronto, looking at long-term visual and anatomic outcomes for PFV, found that only 35% of patients with PFV improved to 2200 or better. Therefore, delaying lens-based surgery where possible, coupled with strict compliance, may in fact improve long-term visual outcome. Postoperative considerations. Early amblyopia care should be administered. Aphakic patients should have contact lenses or glasses prescribed within the first few weeks of surgery, and part-time occlusion titrated based on the amount of amblyopia and the age of the child. In infants, glasses are preferred as they are more easily changeable. The goal of near vision is important as most infants' visual acuity and visual tasks occur at near. And if you're considering a contact lens, they can be used, but more effort is required from caregiver and participation from the patient. In conclusion, there is limited data comparing non-surgical versus surgical management. PFV has variable manifestations and presents a therapeutic challenge. Therefore, cautious case selection is imperative when opting for medical management over surgical management, but can be successful with good compliance, as exhibited in this case. A key takeaway from the case today is when poor compliance occurs in the pediatric population, stop, reassess, and respond. And finally, pediatric cataract surgery is complicated for a multitude of reasons, and so why close attention to detail is required pre, intra, and postoperatively. This high standard of care is imperative for the child's final usable vision.
That was excellent, Anish. There's a question from Dr. Kraft. His hand is up.
Yeah, hi, Anisha. Excellent presentation. Just one other thing you were saying about the option of glasses. It's not optional, it's compulsory. And you've heard me talk ad nauseum for years, but the fact if a child has poor vision in 20/50 in one eye, it's mandatory that you prescribe safety glasses, safety lenses. So whether or not you're using contact lenses, whatever you're going to do with this child, never let them leave the clinic without a prescription for safety lenses. And that's one of the most vital things you're going to get out of this whole presentation.
Good point, Dr. Kraft. Thank you.
Guys, can you elaborate on when you have that really young child that you're not going to put an IOL in, but obviously the posterior capsule is going to pacify, I presume you have to remove it. How do you approach an eventual surgery to replace their lens when they're older?
So very good question. So just to add a little bit before we answer that question. So Anish mentioned that, we want to get visual rehabilitation done as soon as possible. And basically nowadays what we are doing is that the time to rehabilitation is literally 0. So we do the surgery, we do intracameral moxifloxacin, and we put a calculated lens, contact lens on the eye as the kid is waking up. So literally they wake up very similar to adults with just a clear shield on their eye, and we expect that to start the rehabilitation. So it's no longer the wait of 1 to 2, 3 weeks to get a contact lens fit, order it in and do that. So I think the whole concept has moved forward significantly because of all the advancements that has been made. So that's the first thing. And the good point that you bring up is the secondary IOL option. So We actually do have some surgical videos that we use for teaching, but basically what happens is that when you remove the anterior and posterior capsule, they fuse together and you basically get a donut shape going around, which is the Summering's ring. So our standard technique now at Sick Kids is to, when it comes to the surgery, you just open up in front of where the adhesions happen. So there's a fibrous ring in the center of that donut, which is your safety basket, if you like. We 360-degree open in front of that fibrous capsule, and we basically take out the Summering's ring, because if you try and put a secondary IOL into the sulcus, the bulk of that ring will push the IOL towards the iris, and you get a significant amount of iris chafing. And so we have to flatten that, even though it looks like the IOL will fit nicely into the sulcus, it's pushed against the iris. So we suck out the Summering's 360-degree, and then if there's enough bag, we can put it in the bag, but usually you end up with a sulcus placement and you posterior optic capture the IOL. And that works really well. You have usually at the time of surgery, anterior capsular opening of about 5.5 millimeters and a posterior capsule of 5 millimeters. So that ring is actually very strong for basically any of our modern 3-piece IOLs to go into. And then you just enlarge it a little bit for the posterior capture, and it actually sits quite nicely and it's very secure. So that's what we do. And generally, I leave it to the parents to decide when they want that done. Usually by the age of 3 to 5, they're kind of beginning to get fed up with contact lenses. The kid wants to have sleepovers at their friends. They want to go swimming more often. So contact lenses become a bit of a nuisance for them. So then that's usually when we actually do that. And at that stage, the Summering's is still quite a liquid that you can just suck it out. Beyond that, I've done teenagers where the Summering's was just one calcified donut. So the longer you leave it in theory, the more problematic it is. And I suspect this is what you see in the adult world a lot more often. That Summering's becomes extremely tough, and when it's calcified, you just have to open up the wound and remove it. There's no fragmentome or phaco that can touch those, unfortunately. They're literally rocks. So we do, have videos on this when we do for our anterior segment teaching. So if any of the juniors are wanting to see that, we could play that at any stage. So I just wanted to see if there was any other questions, but just before, thank you for Yogesh and Anish for those cases. And again, just the whole compliance adherence is very important. With this case specifically, if I could mention that some parents, the kids are going to do well no matter what you do. And some parents, unfortunately, misunderstand surgery as a way of stopping glasses, contact lenses, and patching. And that's very, very important. So a lot of times, whether it's an accommodative esotropia, whether it's a cataract, whatever it is, parents need to be reminded that just because you are having surgery for your esotropia doesn't mean you don't need glasses anymore. Or if you have cataract surgery or a secondary IOL, doesn't mean you can stop patching. So that's a secondary level. And it's very important for people to understand, because compliance really shoots down if they don't. And that's a big problem. And with this patient, the parents were amazing. And 2-line difference between the two eyes is actually quite a good outcome for any unilateral cataract, let alone PFV. And that's because they patched well right from the beginning. And as it turns out, in this case, we have Anish, I don't know if you could go back to the original photo, if you don't mind, just go through some of the principles. We usually say that if you have a 3 millimeter opacity centrally, or smaller than that, you can just patch around it. So in theory, you could argue that at this case, this patient was quite borderline for just non-surgical management. What Anish was mentioning is that this kid had very bad severe eczema. Basically, the entire face was red and scaly, and they rubbing the eyes all the time. So I was very happy to do a non-surgical management whilst the protopic and everything else started working on the eczema. And then basically over the course of that, whilst the skin was getting better, we found that the parents were actually doing very well with the patching, and the kid was actually quite functional. So we thought, well, maybe we could get away with this borderline case on the non-surgical management. And as you heard, they did really well. But the other thing is that, as a reminder, because it has happened, people with periocular eczema and atopic disease basically chronically harbor MRSA. So whenever you are operating on anybody who's an atope, you have to, I think now, really think about MRSA, because they can have horrible endophthalmitis or infections, whether it's corneal surgery or otherwise. And there are recommendations coming on now that you probably do need to treat patients for MRSA if they're atopes and you're doing any intraocular surgery. And you'll be amazed how many of them are colonized with MRSA. And if you're unlucky, you're gonna get an infection post-op. So it's just other things to consider. Great, on that point, thank you everybody for your attention and good questions.
Franny.
And
I think Elise's dog has some points to raise.
That's right, yeah. He doesn't agree with the management options.
He didn't like that MRSA comment, Camille.
No, she's clean.
Hey, Camille, can I ask you, thank you to you and Yogi and Anish for the great presentations. Compliance is always very difficult with patching. Can you just remind us some of the strategies you use when you really come up against difficult patching issues where patching isn't happening with kids?
Yeah, so the million-dollar question, right? So I think the first thing is understanding of the parents. So if they see the importance of it, I think that's the main thing. If they don't see the importance of it, then it becomes a problem. And by importance of it, I think it also means understanding. So a lot of people say, well, I've been patching for, let's say, 6 months and the kid's still turning in. And we said, okay, no, the patching is not for the esotropia. It's to improve the vision. So you have to really, you'd be amazed how much people actually misunderstand why they're doing what they're doing. So that's the first thing. So if they think, well, it's not doing anything because the eye is still turned in, even though you're saying, oh, they're doing really well because the vision's gone up 5 lines, they need to understand that you're talking about the vision, because they're going to go home and say, well, it didn't do anything. And he keeps saying, oh, it's so good. Whereas you have to understand that you're saying the same thing. So that is a major issue. And the second one is obviously just them understanding. And I do tell parents that, with the difficult kids that don't want to do patching, and especially when you're starting out, you can't just put a patch on and then go and start cooking dinner. Because literally, as soon as your back is turned, you need to, the patch comes off. So especially as you're starting, you need to be sitting. You've got to have that 1 hour of special time with the kid. Maybe if they have a favorite TV program or an iPad or a game, you sit with them. The patch goes on when they're doing their favorite things, with you pretty much watching them and holding the arms down until they kind of get used to that fact. And again, it has to be strict. I say, you know what, if your kid says, I don't want to go to school, you say, no, you're doing it. It's not that they have that much of an option. And I think parents, we always parents know it's very tough, but so they kind of have to understand that, if she says, don't want to go to school, you're not going to take that. So why would you take this? And again, I think sometimes when it is totally impossible, single parent, a lot of other kids around, then you just have to say, you know what, this is not working. And we always have atropine, which is a great option. The problem with atropine is that if they have very dense amblyopia, even the atropinized eye may see better than the other one. So it may not work. So you kind of have to decide on that. But atropine is great because now we know that if you just give it Friday and Saturday night, it's 100% gone in, and it kind of has a slow effect all week. So it does actually improve the moderate amblyopes quite significantly. And the one other trick which we kind of instinctively use is that with bilateral cataracts that have contact lenses, and one eye is a bit worse than the other one, you just say, Mom, take out the contact lens in the good eye 2 hours earlier than the bad eye, or put it in 2 hours later, because that equals 2 hours of patching or optical penalization. So there are different tricks that I think, depending on circumstances, you can use a combination of. But you're right. We do tell them it's the hardest thing you do. And at the end of the day, it's the only thing we can do at the moment. You know, once the kid improves a little bit, it becomes easier if they start functioning with II better. But yeah, there's no easy way around, unfortunately. Nothing's improved in that side of ophthalmology for a while. It's a very good question.
We do have
Or just one comment from Dave Smith. You want to ask the parents which eye they're patching, and sometimes they've been patching the wrong eye the whole time. So you ask them to show you the eye they're putting the patch on in the clinic.
Yeah, when the compliance is extremely good, but the vision is not improving, I think that's a very good point. Oh yeah, he keeps it on for hours a day. Actually, that's the other very good point that Dave brought up. So so one of the things that works very well is patching the kids in kindergarten, because they listen to the teacher. So if the teacher says, don't take that off, they listen. So what we say is that if they patch for those 3 hours at school, it actually is more successful. For one, the kids distracted, they're playing. And the other thing is that, you know, if the teacher says, don't take it off, they'll keep it on. And the trick there is to make sure the parents put the patch on the correct eye and then send to school rather than the school puts it on, because they go to school and this kindergarten teacher has 20 kids in there and says, Johnny, which eye am I patching? And Johnny will clearly point to the wrong one. So if the teacher is putting it on, they put it on the wrong eye. So you have to make sure parents put it on the correct eye, then they go to school, and then actually surprisingly it stays on for more hours than you think, because they have more authority teachers than parents.
You can't trust little Johnny. I think Dr. Kraft might have a comment. He's got a hand raised. Let's go to him.
No, I was just going to say, Kamiar covered most of the tricks and rules of the trade. Just a couple of things just to underscore that sometimes you have to bargain with the parents. You know, they may have a very strict code that when the kid comes home, that they can't be on the video games and whatever. And I think what you got to do is strike a balance and tell them that if it keeps the kid's attention and they will actually hold it closer, don't forget it in a near position, the vision's actually a little bit better, and you know, even an amblyopic kid might actually see a little bit better. So that if they have to hold their video screen closer, you might get better compliance if they're doing games that they like to do. The other thing is that some of you may be aware that there are these new paradigms of what are called binocular dichoptic amblyopia treatments, and there's a lot of studies going on now with specialized vision, with artificial vision and so on, to try and allow kids to wear these goggles that actually on video screens can give them a dichoptic, you know, a differentiation between the two eyes, but to try and reduce the suppression of the amblyopic eye. And there's a lot of work going into this. It's not commercially available yet, but we may hear in the next 5 to 10 years that there'll be modules that will allow kids to use both eyes open with these specialized video screens. And it's quite exciting. And this is true even for kids with strabismus. So it's not state of the art yet, but we're getting closer to be able to do treatments in some kids without patching or atropine. And the other thing is that recent studies have shown some other interesting things about the treatment of amblyopia. If you have a child who is who has anisometropia, for instance, and strabismus, and you give them the glasses, they may actually improve without patching for the first little while. It's the same as we do with kids with just straight eyes and anisometropia. You have several months to just give them glasses and see how they do. It turns out the same thing is occurring also with kids with strabismus. So even though they have the double whammy of, let's say, refractive anisometropia as well as strabismus, you can still get away with glasses at the beginning and watch them for a few months, because many of those kids will actually improve. And when you get them to the stage where they'll accept a patch, then you can improve them the rest of the way. So there's all these new paradigms that are coming up. And so anything that makes it easier on us and easier on the parents and easier on the children are certainly going to be advocated. But, you know, maybe in the next 5 years, we'll hear about these binocular treatments that they'll, you know, be able to be more commercially and widely available. And so word is still out on that, but we'll let you know as that comes into clinical practice.
All right, thank you, everyone. Great rounds. Any closing comments, Camiar, and then we'll sign off.
No, just Nancy was asking how do you pre-treat MRSA. So I just made a note there that the bacteriocin ointment up the nose, that's where the colonization is, and Perrier, sort of the groin area. Sorry, I can't think of the name. So, and also doxycycline by mouth are good treatments for pre-treating, and you just need to have them re-swab to make sure that they're negative for MRSA. But there's some protocols that your local ID person would have, or the family physician, but those are some of the ones that they use. But you can eradicate MRSA from the areas that are close to the eye for sure, but they actually need to swab negative at all areas for them to actually clear it. Great. Thank you again to Yogesh and Anish. Thanks for all the great questions, and have a great Friday and weekend. Take care.
Take care, everyone. Have a good weekend.